Hi, everyone, and welcome to another episode of Office Hours, where we unpack the toughest challenges in revenue cycle management with the people that actually living them every single day. And today is no exception because we're going to be talking about a session that's titled From Prior Authorization Chaos to Clear AI Orchestration. And that's pretty much says it all. We're talking about disconnect between how fast care is delivered and how painfully slow and fragmented prior authorization still is. And joining me today is someone who's actually is living it, to take that, to coin that phrase, and knows all about this topic inside and out. It's Evan Martin, who's the VP of Revenue Cycle Management at ZoomCare and is also the co-host of Wearshow Group's IT RevCast. So, Evan's always good to have you on. How are you doing today?
I'm doing great. Thanks for having me back. I'm super excited about this topic. I actually just wrapped up recording a podcast a little bit about AI, and prior auth was a little slice of that episode. So,
Nice, nice. So we get to expand on that. Yeah.
yeah.
So you've kind of had a dry run. That's awesome. That's awesome. So yeah, and I encourage everyone to go if you have not subscribed to the Wisher IT Revcast. It's actually a very excellent podcast. Evan does a great job, out there. I listen to it. It's wonderful insights that you can gain. So always like to collaborate with him on these issues. And particularly for today, we're going to cover a lot in this conversation of what happens when patients self-schedule and show up before the paperwork can even catch up. Why retroactive authorizations are becoming the norm and what that's doing to clinical teams. And then where does this agentic AI fit in? How could it finally bring some clarity to this mess? And then Evan's wish list is what we're going to talk about. If he was to be called and said suddenly, hey, you're head of CMS, or maybe you're head of a commercial carrier payer. So we're going to talk about, how you would handle this if you were handed the reins, so to speak. So before we dive in, though, I just want to have a quick reminder for everyone that we'll leave time for audience Q&A at the end. So if you've got a question, please drop it in the chat. You can go ahead and drop it in now, so we can kind of formulate the questions. Sometimes questions are very common, and so I love it when I see that. It means everyone's on the same page. So with that, Evan, we're just going to jump right in. You ready to go?
Sounds great.
Awesome. So let's start with the reality on the ground. You've mentioned that the majority of your patients self-schedule and arrive same day. So how do you even begin to handle prior authorizations in that situation, uh, in time, and that kind of in that kind of care model?
Yeah, I mean, one, being a patient of my organization and being on the opposite side of it, on the operational side of it, definitely you see the value of both. So for your audience a little bit, so Zoom Care, we're a 50 clinic primary care practice with some specialty services, including emergency specialty services in the Pacific Northwest. And our whole model has always been on-demand scheduling for your primary care provider. Whether you've designated a specific clinic or a specific provider, the goal is that you can schedule same day. So about 80% of our patients schedules either same day or schedule for themselves. They have very little interaction with our actual scheduling department and team. Which is great for us because it means patients are driving their own care model. But to Stuart's point earlier, it does impact us quite a bit, especially if you're scheduling your own advanced imaging, for instance, because you can do that with us. You know that your provider at your primary care referred you over to my super location for a CT, and you're going to schedule that on your own. And it could be that you want that open slot that's today. So we find ourselves constantly having to now embark with what a lot of organizations are of the demand of, do we get the patient in because we want to do timely care and treatment? And we fight the good fight of a retro authorization, or do we go and say, no, we need to delay you out a day and here's why, and try to do an urgent authorization? And to be truthfully honest, we fight the good fight here at Zoom Care, and we also will do same day urgent authorizations. We do have authorization specialists Monday through Friday who do that for us. But that is one of our struggles that I think, is it about delivering quick care, or is it about in quality care, or is it about, jumping through the hoops in the game? And we've made the option to go with quality care at the fastest point of offer out there, and do that fight. And that really does drive for a large number of medical records requests, a large number of prior auth having to go and do retro authorization requests within a certain time period and time frame. And what adds demand and complexity, I think that a lot of us are starting to have to face, especially in the urgent care or immediate care spaces, where we're seeing, we're not offering full emergency services and not full emergency care or urgent care services, but same day on demand type of components, which is a lot of health systems are now popping up those groups. Is how do you get that for labs? How do you get that for the medication that you might have to use that has to come from a specialty pharmacy? We're seeing a
Mm.
lot of that complexity, which is not even special medication sometimes. I mean, I even know, like, when I went to go get a prescription filled, I have to get all my scripts from a mail order pharmacy. But if I need an antibiotic today, I have to pick a place where I can get that antibiotic when I'm leaving that clinic. Not, I can't just
Right,
get it from a CVS without prior auth now. So
right,
that our healthcare system, as we all know, is just making it so complex that I think we're going to have to say, is it about care? And then it's the administrative after fact.
right. Yeah, excellent points. And I know that you mentioned earlier about, retroactive authorization. So let's say treatment happens first. The patient's already been seen. What does it look like when your team has to go back and secure authorization after the fact? How do you avoid denials in those situations?
Yeah, I mean, our team really, what we've done is we've created some templates for our authorization group to say if it's this service and it's this payer group, dynamic group based off of what their requirements are, auto pull this information that we delivered and auto pull what was the decision-making documentation tied to that, and just submit it as a retro auth within that 24-hour retro auth period. What I get concerned about is and I think what everybody should get concerned about is our hours of operation. My auth people work from 7 to 5, but my clinics are open from 7 to 10. So, and even some of my primary care are open later in the evening, right? So, them doing services or referring a patient to a service for the next day, we might not pick that up till the next day for an auth that was already scheduled for an x-ray at 7 a.m. when the clinic first opened. So that's where we are seeing we're having to develop buckets. And then really we're stepping back now to Stuart and saying, what what's out there in the industry for an AI agent or AI capability or technology base that could pre-grab that information for our team member to review it and then be that expert reviewer and then the submitter and then say, yep, it's ready for submission, versus them having to collect all of these across 50 clinics. And I'm in a unique spot. I only have one primary prior auth person with a couple secondary backups during the day. So high volume day, we pull people from other functional duties to support. Low volume
Sure.
day, it's one person that's trying to pull those aspects based off plans, based off requirements, which makes it even more complex. And I can only imagine, well, I did live it in my past lives, right? At a health system, it's even more complex there, where they really are saying, is this prior auth required or not? And thankfully, CMS backed out of their whole one legislation they had a couple years ago where advanced imaging had to hit a certain care cord score, but that didn't mean that our you know our health plan partners didn't continue to still adopt that requirement in that
Mhm.
structure, even though CMS backed out.
Right. And I know you're also in a unique situation where, your place of service matters, to a large extent, when dealing with prior auths as well. And I know you mentioned also that, the staffing, you have one person handling all 50 clinics, which is astonishing. No wonder, yes, you got to pull additional staff. And so that kind of leads into the next question about talking about solutions, talking about technology and how that can help. So, with staffing, we've certainly encountered that where, yeah, maybe we can add some digital agents, if you will, where you don't have to expand, or maybe you can use those agents when it is high volume. So you've described a need for agentic AI that's more than just automation. Everyone's heard of automation before, the bots, the RPAs, whatnot, but the agentic AI is unique. We've discussed this ad nauseum, here at Infinix with a lot of our content, but something that actually understands and routes the work.
Right.
So, what would, in your mind, what would a truly intelligent system need, to do to move the needle on prior auth?
Yeah, I think, as I look at business partners out there, Infinix included, and others, I think the biggest thing is how do we adopt education to that AI, and how do we set what our standards and workflows are by individual organizations, and what's that risk factor? I'm constantly having this conversation of what risk are we willing as an organization to accept, around compliance and complexity, but also what is that risk factor of to our staff of having them teach the component and realize that they are the expert still, and they're teaching the AI their brain dump, and
Mm.
then they themselves have to continue to grow and be constantly teaching these agents, right? So I think that's really where we need to get past the RPA of like, hey, go screen scrape this and go grab this data and all of that. We need these agents to actually be able to be decision makers and take not just a what if statement and then do this, but hey, this new thing's presented. There is a new policy. Do I need to go to another agent and learn that policy, or do I need to actually queue this up for somebody else to support? And that's really where I think I really want my team and I want others to get around the whole concept of AI is it's not replacing our teams. It's enhancing our team's ability to be that knowledge expert and teach something to do those more mundane tasks. Because if it's a prior auth like 4 days from now, right? Give that to an agent every day. Let him do that. If it's,
Mhm.
I need a prior auth in the next 20 minutes for this CT with contrast and then an x-ray and an ultrasound for all three of these advanced imaging procedures, I need the agent to go pull all that information while my person is the person on the phone, because that's what's going to require to engage back with the person to be able to answer that and make sure everything's uploaded in there. So it really does change how we need it. And we need those different agents from whoever our business partner is to say, okay, this agent's going to be doing this for us. This agent's going to be doing this. And this is where my person sits in the middle to be that steer, that guide for those agents still and interact with when we need an interaction live.
Right, exactly. And it is all about timing, is what we're kind of talking about here.
Really,
Because
down, yeah, it
yeah,
totally comes down to that time for us.
yeah. It's like, that I need this now. I don't have time to wait, and it's already a pain to go out and try and search for these prior auths, depending upon the payer, depending upon the method of trying to communicate, whether it's through a payer portal, whether it's picking up the phone. Um, Everyone understands the pains and aggravations that go along with that. But when you have a patient right in front of you and they need to be seen right now, that's, yeah, you need something to interact very quickly. And I know that's what AI agents can do, is they are like human specialists. They're designed to mimic human specialist and, to your point, augment the staff and augment those human specialists. But in essence, they're able to process that information and handle those tasks at a much accelerated rate than a human can. And that's going to be there's many benefits, but that's really one of the main benefits as well.
And I think that's what gets me excited. And talking with my peers is like they can do that portion lightning speed, and they can even have an agent who's connecting our person and doing all of that portion so that when it's the person that needs to now have the conversation, it's a there you go. And all the information's right there in front of them so that they can have that interaction and have that clinical conversation. Um, I think agents eventually will get there in that clinical conversation as well. I think that's where sometimes human to human, because they want something else, you know,
Right.
okay, what does that look like? And we can still leverage the agent to pull that next portion. So in my mind, it's having an agent my human agent on the phone with an ambient AI agent listening that's telling our generative AI agent to go pull all of these other aspects and throw it up on their screen. I mean, it's kind
Right.
I don't remember what that movie is, but I just see like, the plastic screen there and all the data. It's almost like Iron Man with he's just touching things in the air and moving things around,
Right.
but and
Exactly.
Jarvis is just throwing it out there. I think we're going to get there for our prior auth team someday. I'm hoping soon so that they can have more of those resources at their fingertips. And honestly, they're so important. We should be paying them more for that brain that they have out there and doing that information as well.
Oh, absolutely. So I couldn't agree more. So now I want to dig into one of your real pain points is in-room procedures and injectable medications. I know this is near and dear to your heart. So how does the split between medical and pharmacy benefits complicate those authorizations? And what does that mean for providers trying to act in the moment, that urgency, so to speak?
Yeah, I mean, this really goes back to what place of service are we billing it at, and are they, and how are we doing that? So, in prepping for this today, I was really thinking through this where at Zoom Care, everything's place of service 11 for me here. And, in an urgent care setting in a place of service 20, I have that Rolodex of meds that I don't have to get prior auth or it doesn't have to come from a specialty pharmacy. But in trying to lower care cost in the care delivery model, which is something near and dear to Zoom Care's heart, we've really taken a hard stance that we're billing at a place of service 11, which opens up this gate of almost all of our injectables have to be either prior authed or they might even have to be, white bagged or brown bagged, depending on the requirement from that insurance coverage and knowing where the med comes. And that adds that complexity of where I really see right now there is this need for us to have an agent that can take the patient's plan and give that guide back to the physician at the time to say, hey, I know you need this med, but we either need to prior auth it and have it going out there and doing that prior auth as it's ordering the med, the provider's ordering that med up for that in-clinic injectable, or it needs to say red alert. I know you don't want to read, like it gives them the if or like we could go this route. If so, we'll have that agent start to activate that. If you say no, let's give the patient the opportunity, which in my mind it's the patient's right to say, oh nope, let's just wait. I can come back, and reschedule or schedule for that next appointment. Then, gives them that. But I think that's where the complexity, I think, really falls in. And we're even seeing some of the just traditional medications that are used in clinics now, even requiring some prior authorizations where flu shots. I had a limited plan prior in my life that I couldn't even get my flu shot in my provider's clinic unless I wanted to pay full price myself. I had to go to a retail pharmacy location to get it,
Mhm.
and makes it complex, right? It's middle of flu season. I know they have it there. Do I want to pay the $40 or do I want to go and get it for free at that location? And I think, my provider always encouraged me to get it in the clinic, and I'm like, but it's free for me elsewhere, and that's why I'm going to go elsewhere for it. And I think that's a hard line because you our providers are trying to deliver the full care at that time, but as a patient, they're having to know. And I think that's where we really do need around prior auth. What are those parameters and what is that? And I know I'm leading into my wish list down the road of like if I was
Sure, sure,
CMS
yeah.
or a health plan, but I do think that's part of the component of what's right for the patient, not what's right for us as a medical system or a health plan system. So,
Yeah, because patients vary. We've always, I mean, I'm only given into the social determinants of health, issue and that no one really used those codes because they weren't reimbursable, but now they matter because it's varies against from patient to patient.
right.
And, are you dealing with someone who's homeless? Or are you dealing with someone who is blue collar, has a job, has some good insurance? Or are you dealing with someone who's on a high deductible plan? All these variables really matter, to educate the patient on, what institutes that care, because the clinic from a clinical standpoint, you want that care to happen immediately, it right there in one spot. That's ideal. But from a fiduciary standpoint, that's the patient's call. Let the patient decide what course of action they want to take. So, um, Now, speaking of that, touching on clinicals, we often hear about the gap between clinical judgment and authorization rules. Um, from your experience, how have providers' intent and medical necessity clashed with the true auth process, that what allows or what is denied?
Yeah, I think that is an age-old question, at least as long as I've been in healthcare. If it's always a constant clash. And I think that first and foremost, I always remind my providers, your clinical judgment is the call. And while we aren't set out to know even in revenue cycle, we're not set out to know every single policy and payer guideline and rule. We're gonna do our darndest to get everybody generally educated around what is that. But I think where it's clashed is providers feel an obligation to the patients to have to know those rules versus saying, hey, do in changing the script. And I think we need to give our providers and our clinicians better scripting to say, you know what, I don't know. And it's okay to say, I don't know what your policy fully is. It's not alerting me in my EHR system today. Um, but this is what I would recommend for your course, and it potentially could cost you this as an out and if it's not covered, right? And I think that's the conversation. It goes back to that age-old Medicare component of an ABN of saying it's the provider educating the patient that this could cause them something, and they understand the risk of there could be a financial responsibility there and what that financial responsibility could look like. I think that is where authorization and policy have always collided with clinical care. And ultimately, the patient and the provider need to make that decision. And then we're going to do our darndest on the back end ethically to support the patient and that provider clinical care. In some organizations, I know, especially us, is if we had the conversation ABN signed, patient understood risk. If ABN not signed and provider didn't push it because they were still pushing, we're going to appeal it and do our darndest on that. And then come back and talk with the provider about, hey, is this a policy trend? Is this an issue? Is it a specific policy with that pair we need to educate them to and put more flags or best practice alerts into the systems? I think that's where I don't think that's going to change. What I would love though is something to constantly be out there scrubbing and giving those best practice alerts to the provider, because my team can't keep up with that. Your teams can't keep up with that in the industry either. So that's where I think we're going to have to rely on active agents that are fully integrated with our EMR and the health plan networks to grab those rules to be able to give them those alerts. There's just too much to go through the Rolodex of everybody.
Oh, I totally agree. And just a quick note, I know medical necessity has always been kind of a objective or subjective frame of mind based on if you're talking from a clinical point of view or from a prior authorization or policy point of view. And I think policy is winning because when people talk about medical necessity, they're talking about, well, what does the policy say? What will pay this? Well,
Right.
but it's also there's the clinical side where this is clinically defensible, that it's medically necessary. That then, according to a provider's clinical judgment, who actually went to medical school and spent hours and hours and hours, in residency and experience based on seeing the same condition over and over. This is the clinical judgment of how to best care for this. And when those collide, I think you make a good point of having AI pull all of that together.
Yeah.
Here are the policies, here's what your carrier is saying, not to point fingers, but just to educate so they can
Yeah.
make an informed decision. But from a clinical judgment, this is the best course of action. And there are justifiable reasons why a carrier may want, to take a different route. It's all about controlling cost. It's all about, and that's with the patient in mind in a lot of instances, but most times it's with the carrier in mind. Um, so yeah, excellent points there. So as we wrap up here, we are going to get to your wish list now. So let's zoom out. If CMS or a commercial payer called you tomorrow and said, we're ready to rethink prior auth altogether, where should we start? What would your blueprint look like?
I think the first blueprint would be, what's the intent to prior auth? Is it really around understanding what care delivery model is going to be, or is it around putting in a barrier or safeguard to save you money so that we're not just going with this huge perception that providers are going to order a kitchen sink, right? Like I have this conversation constantly in the Pacific Northwest where I'm located of we don't get enough vitamin D, just prescribe our patients vitamin D, right? But there
Yep.
are certain medications that adverse react to that and all of that, and that's not in our diagnosis code. So I think the component that we really need to say is medical judgment needs to come first, and that's first and foremost my biggest wish is we are entrusting these people when we give them a medical license in our state and in our country to be using their medical judgment, allow them that judgment call to order what's needed, do a retro review, and then determine, hey, this isn't against our policy. This is against your medical practice organization's best practice guide. And I think that's what we have to get back to is what is that? If I go to emergency medicine and look up what is their foundation of clinical care, that's what I'm looking towards. Same thing when I can remember my partner being in the hospital a year ago, Stuart, and my first question to the pulmonologist was why he was having a bilateral pulmonary embolism was, why are you not sending him for advanced imaging? Like, and why, if you know where it's located and it's feasible, are you not going in and doing an adverse thing versus him now having to be on blood thinners the rest? And it came back to it came back to health plan policy versus clinical decision of what their practice association actually said was best practice to do, right? And what is supported through literature and documentation and everything. So I think that's where my wish list is. Let's throw prior auth out and let's get back to what is the specialty and what is national studies are showing and guidance and research is indicating is the best component versus saying, hey, that's still experimental, even though studies have proven this and said that. I think that's where CMS as a governing board needs to go and have part of their team taking that and saying, nope, everybody's going to now adhere to this regardless what type of plan you are. You're going to follow under what is that study indication and what has been adopted by those specialty practice associations, because that's really the guide. I mean, we rely on AMA as a practice to tell us how to code things. What's the difference if we're looking at it from a respiratory perspective, a pulmonology, dermatology, cardiac? Those are the groups of those thinkers across the nation world really coming together and saying, hey, this is what is the best medical indicators for you to make these clinical decisions.
Sure. Excellent. Excellent. So I do think we have a couple minutes left. It's time to turn it over to Q&A. So if anyone does have a question, please put it in the Q&A comments. We do have one. We probably only have time for one here. So this question comes in, Evan, which part of your prior auth workflow causes the most delays? And have any tools actually solved it?
Yeah, I think the workflow part that causes the most delays is gathering the information. And I think that's where partnering with business partners out there who are developing and have already developed these AI agents and generative AI to go pull and grab that information and consolidate it quickly for your team to then review and see if anything's missing prior to submission is really the part. It's not the clicking of the button and uploading it, it's the consolidation component that takes the longest to pull those clinical key aspects into the request with the supporting documentation up front.
Yeah, gathering that information, we could talk a whole nother hour on that
Absolutely.
and how to improve that for sure. But we don't have an hour, so we are wrapping up here. Evan, as always, love having you on. I think you're going to be a main feature that comes on pretty frequently going forward. So definitely love having you here. So thanks for being here with us.
Yeah, thanks for having me again. I love the conversation and being able to join in. So
Yeah, awesome, awesome. And then thanks for everyone else for attending today. We will have this as well on demand. You go to our website, probably in the next 24 hours or so, you'll be able to watch this again. If you just couldn't get enough or you wanted to share it with a colleague, be sure to reach out and share that link with them, and they can come on our website and watch this again. Until next time, we'll see you next week, and I want to appreciate everyone joining us today.